as things stand currently, patients with bladder cancer require ongoing surveillance, and it's very time consuming because you have to get the patient into hospital and use a flexible cystoscopy to look at the bladder. The patients find it uncomfortable. So there's potentially a huge benefit to using a urine-based biomarker, so that all the patient has to do is to produce a urine sample, and then you can run a test on that urine sample. So that's the exciting bit about these new biomarkers, that they can hopefully replace more invasive tests for the patient. The thing that's a challenge then, obviously, is to identify the abnormal cancer cells in the urine. So what we've traditionally used is to look at the urine under the microscope. That's called urine cytology. That's been around for a long time, but it has got some limitations. And so what you're trying to do is to pick up cancer cells across the entire spectrum of bladder cancer. And one of the problems that all these biomarkers have is that we have, generally speaking, three different groups of bladder cancer patients. They're low risk, intermediate risk, and high risk patients. And the low risk patients make up the majority of the patients that we're following up. But they actually shed relatively few cancer cells into the urine. And so one of the problems we have with these urine-based biomarkers is that they're very sensitive, which means that they pick up a lot of cancer patients and high-risk patients because they're shedding a lot of cancer cells into the urine. And on the other hand, with low-risk patients, which make up the majority of the patients, they don't seem to be able to pick up these patients reliably enough through urine-based testing. So we're in the current position whereby low-risk patients, probably you couldn't really replace doing flexible cystoscopy with these urine-based markers. And on the other hand, one of the points in my talk is that we still would, as urologists, feel reluctant to abandon visually seeing the lining of the bladder in high-risk patients. Even if the tests were very reliable, you just would feel more comfortable making sure that you haven't missed anything by visually looking at the bladder. So we're in a slightly difficult position at the moment because although the tests are very promising, ideally what you want is for them to identify the low-risk patients very reliably, because if that was the case, then I think most urologists would feel comfortable stopping flexible cystoscopy with low-risk patients because they don't have a great risk of developing invasive cancer and metastasis. But unfortunately, that's exactly the place where the urine-based tests at the moment are not particularly sensitive.